All right, welcome everyone. For the sake of time, we're going to go ahead and get started. Welcome everyone to APAMSA's 2025 Bootcamp Series, Internal Medicine Edition. I'm Kelly. I'm one of the alumni directors for APAMSA this year. I'm going to first turn it over to Ray, Dr. Ray Hu, representing the APAMSA Alumni Board for a few quick words.
Wonderful. Good evening, everyone. My name is Ray Hu. I am an interventional cardiology fellow at Cedars-Sinai in LA and former president of National APAMSA from 2016 to 2018. 7 years ago, I started this bootcamp series because I noticed that there's a wealth of resources dedicated to acing your med school clerkship and step exams, but it was much more difficult to find teaching material dedicated to this unique window where you're transitioning into sub-internship or internship, where you're starting to place orders, where you're starting to need to know the dose of medications. I'm really pleased at how much energy and growth we've seen through the years, considering that we are all volunteers here. And I hope that in the next 2 hours, we'll be able to give you some tangible clinical pearls as well. It's an honor to have five stellar residents, Tiffany Hu, Ramya, Sampath, and Lucia Yu from Yale, Spenser Chen from Penn, and Ming Lin from Medical College of Wisconsin to give today's teaching on core topics on internal medicine. And I want to emphasize that this is not a random selection of residents of whoever we were able to get to do this, but this is the best of the best. Residents who have been nominated by their peers for their passion in teaching and recognized with teaching awards at the institutions, who really care about med ed and pedagogy. I will hand it over to our National Board student leaders, Kelly and Elizabeth, to orient you to today's format.
All right, so welcome again to our Internal Medicine Bootcamp session. As a reminder, this is our second of 7 bootcamp sessions this year. We have surgery coming up on Sunday, and then family medicine, EKG, emergency medicine, and radiology coming up in May. These are just really great sessions with really great residents going over high yield information, whether you're a sub-I or an intern. So highly encourage you to check these out. If you need any help getting the registration links, feel free to DM me here on Zoom or send us an email, alumni@apamsa.org. And then just some ground rules for audience participation. While the presenting resident is speaking, the remaining speakers will answer questions in the chat box. So feel free to just send whatever questions you have in there. And then if there is time for audience participation, please raise your hand to speak. This is just an overview of some of the topics we're going to cover. And for the sake of time, I'm going to go ahead and let the speakers introduce themselves. So first we have Dr. Ming Lin.
Hi, everyone. I'm Ming. I grew up in Minnesota and also lived out in Boston for a good number of my years and went to medical school at MCW and stayed here for residency. I'm just finishing up my intern year. Can't wait. Intern year has been a blast, but a lot of work. I am interested in hematology oncology, do a lot of work in health disparities, especially focused on minority populations. And outside of work and residency, whenever I have the time, I actually love cooking for other people. I love playing board games. I look at the Breville website probably too religiously and dream about my future Breville. And because of this economy, I love deleting emails about my credit score, etc., because ignorance is bliss. So really nice to be here. Thanks for having me and hope to talk with all of you soon.
All right, next we have Dr. Tiffany Hu.
Hi everyone, I'm Tiffany. I'm from Rockville, Maryland. Sorry, I misspelled that. That's actually with a K. I went to University of Michigan for medical school, and I'm currently a PGY3 at Yale IM. I'm in the TRAD IM program or the categorical program, and I'm going into geriatrics fellowship soon. So really excited to be done with residency and moving on to the next step. As far as my interests outside of work, we try to keep our plants alive with variable success. We cuddle a lot with our cats Miko and Nori, and we go quite often to the soft serve place that's right in our community, like 2-minute walk away. It's a dangerous, dangerous place to be living, so close to this ice cream shop called Elena's.
Thank you. Next, we have Dr. Lucia Yu.
Hi everyone, it's my honor to be here. I originally hail from Massachusetts, so not too far away from where I'm currently living in New Haven, Connecticut. I am a PGY3. I can't really quite believe it. The time has gone by really quickly. And I'm going to be going to Vanderbilt for Allergy Immunology Fellowship. On a similar line to Tiffany, I also love cuddling my cat. I also like hiking and cooking and baking in my free time as well. And similar to Ming, I also love cooking for other people. So maybe we can have a cooking party at some point.
Next, we have Dr. Ramya Sampath.
Hi, everyone. I'm Ramya. I grew up in California in Sunnyvale. I have not lived in California for like 15 years. I've been snaking my way through the rest of the country, through Chicago and through Rochester, New York, other places, and now am in Connecticut. I went to med school at the University of Rochester, and now I'm in residency at Yale. I'm a PGY2 in the TRAD or categorical program. It is very difficult to believe that I am soon applying to fellowship in cardiology. And I also love taking care of my plants. I do have a plant ICU called the PLICU. And I did also adopt a dog in October. And so my main other hobby is hugging my dog. I like drinking too many cups of coffee a day. And I have not gotten to do a lot of this in residency, but I hope to, again, be learning languages soon.
And finally, we have Dr. Spenser Chen.
Ramya speaks like 6 languages fluently. I'm Spenser. Hi, friends. I am originally from Taipei, grew up in San Jose, went to medical school with Ramya in Rochester, and I'm now PGY2 in internal medicine and pediatrics at Penn and CHOP. I'm interested in cardiac critical care in adults with congenital heart disease. And I thought I would include a old photo for a shameless plug for MedPeds for students who are interested. Outside of work, I love talking to Ramya, judging bad boba, union organizing. I'm always happy to chat union. I'm wearing my CIR shirt. And also resuscitating my plants. So far, none of them have needed the PLICU transfer, fortunately.
Thank you guys all for being here. I'm going to turn it over to Lucia and Tiffany for the first section.
Yeah.
So what I'm going to be covering at first is essentially vent alarms. As by the title, it's a relatively specific location in which you're going to be exposed to these, namely the ICU. One of the reasons that we chose this topic is because coming in as an intern, I personally had no experience triaging vent alarms. I knew about vents, I knew kind of like what modes they were, but as an intern, you will be responding to these alarms. And so the next few slides we made in conjunction with one of our Palm Crit fellows here at Yale. And so I'll just be going over very briefly what alarms you might experience. So essentially, when you place a patient on the vent, after you determine the vent mode, there's preset ranges for inspiratory pressure, expiratory pressure, respiratory rate, and tidal volume, depending on the mode. Alarms can essentially occur whenever the patient falls outside of these ranges. And so as you can expect, a lot of conditions and a lot of different things can cause something like that. So for example, many of the low pressure, low volume, as well as low PEEP indicates a disconnection with the respiratory, with the vent machine. So there's usually like an endotracheal leak or a disconnection somewhere in the system. You won't often hear nurses or respiratory therapists contacting you about this because they usually are able to triage something like that. The nurse will usually check the tubes. The respiratory therapist will essentially help try to reconnect the system. One of the things that you might hear more often is essentially high pressure or high frequency. High PEEP, high pressure, and high frequency. High frequency essentially means high respiratory rate. So anything that can cause a high respiratory rate on the vent is anything that can cause a high respiratory rate like normally. So if the patient is hypoxic, if the patient has pain and anxiety, then or on the vent specifically, if the sensitivity threshold for the machine is altered in some way. So these are all causes for high respiratory rate. When you have high PEEP, that usually happens with patients with a history of COPD/asthma. Most frequently, it's caused by something called auto PEEPing or air stacking. It's essentially when the patient does not have enough exhalation time to fully breathe out all the air that's in their lungs. The fix is usually to prolong the escalation time. If it's super severe, that is something that I would highly encourage you guys to call your senior, call your fellow, call your attending, because usually the maneuvers to fix a severe auto peeping situation might be to disconnect the vent. It might be to do manual compression. It might be to give medications that will prolong escalation time, like morphine. All of these decisions should be made under the guidance of a fellow or critical care attending. And the alarm that probably requires the most critical thinking would be the high pressure alarms, and that's what we're going to spend the rest of our time going over. And so when you think about high pressure alarms, it's usually caused by either a resistance issue or a compliance issue. And so the first step is to find out whether or not it's one or the other. And the way that you can do this is if you look below at the formula, is that typically speaking, when we think about the lungs, we think about the total pressure in the system as the peak inspiratory pressure. That's the value that's given on usually the main screen on the vents. And then the peak inspiratory pressure is usually a compilation of the resistance pressure and the elastic pressure of the lungs. And so the elastic pressure is essentially a surrogate for compliance. It's what we call peak plateau pressure on the vent. And so the way that you can find out at least two of the variables is by having the respiratory therapist or yourself, once you know how to do this, do an inspiratory hold on the patient. Essentially, what this means is that you ask at the end of the patient's escalation, you ask the respiratory therapist to pause airflow, and that will give you the peak plateau pressure. And so once you have the peak inspiratory pressure and the peak plateau pressure, then you can essentially figure out whether or not it's the peak plateau pressure that's high or the resistance that's high. And just a general caveat, it is very unusual for essentially the peak plateau pressure to be higher than the total peak inspiratory pressure, but it can happen. I would say that if that situation happens to you, that is when you should definitely ask for the fellow attending to be involved. And so some of going into a bit of the differential for essentially high peak inspiratory pressures is when you have the inspiratory hold and you find that the plateau is unchanged, but you have a persistently higher peak inspiratory pressure, then it's likely a resistance issue. There's either a resistance issue means that there's a kink or obstruction. It's somewhere in the vent lung system. And so that either is the tubing is kinked, the endotracheal tube is either blocked by secretions or mucus. Maybe the patient is biting the endotracheal tube, causing a high peak inspiratory pressure. At the level of the bronchus and bronchioli, you can also have reactive airway disease, bronchospasms, or external compression by like a medial sternal mass. And then the other categories, if you say do an inspiratory hold, the peak inspiratory pressure is high, but the plateau is like also high, then it's likely a compliance issue. So the problem is at the level of the alveoli, the chest wall. Mucus plugs can also do this as well. essentially there's some overlap between compliance and resistance with mucus plugs. But at the level of the alveoli, some of the things that to think about in the ICU is whether or not the patient has developed diffuse alveolar hemorrhage, cardiogenic pulmonary edema, like an ARDS type situation, or pneumonia. At the level of the pleura, does the patient have, say, like a pneumothorax, a hemothorax, an empyema, or pleural fusion? Or if they have a pre-existing chest wall conditions. So like they've essentially had surgery on their skin that makes it super tight, or if they are at risk for abdominal compartment syndrome. And so I would say that this is essentially a differential for you guys to use, but obviously there's more nuances and there's overlap. So if you have any questions, please call your local fellow or critical care attending. The next topic that I'm going to broach is a little bit more practical to all aspects of the hospital. It's essentially a talk on delirium. So say you are, especially at night, which is where delirium most often presents. Say you are early in the evening, you have a nurse come and say, Mrs. H is super sleepy. She's very slow to respond. She wasn't like this early in the day. Like, what do you do? Well, obviously, altered mental status has an extremely broad differential, and we're not going to go into all of it on this talk, but we're going to mainly focus on delirium and what to do. And so essentially, when you triage a delirium, there's something that you can use called CAM ICU flow sheet. This is predominantly used in the ICU, but you can use this on the floor as well. So you kind of can go through this flow sheet and ask yourself these questions. So number one is the patient mentally altered? Typically speaking, the nurses are the ones that contact you at night or on cross coverage for a change in mental status, as they're with the patient most of the day. And then what your job is to essentially go to the patient's side and assess them, whether this is something more severe than just delirium or if it's just delirium. One of the ways you can do that is you can essentially assess their attention span. So essentially box 2 kind of demonstrates some of the strategies it takes to or some of the techniques you can use to assess whether or not they have an adequate attention span. If they have over 2 errors, then you just move on to the next box. And so kind of speaking a little bit to RASS, RASS essentially is a clinical scale that tells you the level of sedation. So I've put on very briefly this table where it kind of shows you the RASS scale from +4 to -5. So +4 is extremely combative. Like these are people that are like in immediate danger to themselves and to staff. And then -5 is essentially coma. Ideally, the patient is a 0. They're calm, alert, but interactive. If the patient has essentially a RASS score other than 0, in the ICU, that's considered a delirium present. If the patient is calm and alert and cooperative, then you move on to essentially conceptualized thinking. You ask them questions like, will a stone float on water? Are there fish in the sea? Does one pound weigh more than 2? And essentially, if they get this more than one of these questions wrong, then it's very likely that delirium is present as well. If they're essentially they don't get it wrong, then it's unlikely to be delirium. And so kind of going more into the treatment of delirium, most often what you will see is essentially hypoactive delirium. So essentially what patients present as like sleepy or as like not as responsive as before, rather than the hyperactive, like really agitated delirium. And ideally, the way that you mitigate this is basically about aggressive reorientation. So essentially try to maximize sleeping time as well as normal behaviors, like going to the bathroom, relieving constipation, increasing mobility, having timed meals, having activities during the day, and to essentially treat all the underlying conditions as well as any pain or dehydration. You want to remove all unnecessary lines, drains, or restraint at the earliest opportunity. Obviously, if the patient is a danger to themselves or a fall risk, then restraints might have to be used. In terms of the treatment for hyperactive delirium, I think the first question is to assess, is anyone being harmed? Is the patient being harmed? Is the staff being harmed? Because medication to control agitation does not treat delirium. We currently don't have any medication that fixes delirium for us. And so essentially, before you give somebody an antipsychotic, you need to check an EKG, essentially for QTC prolongation. As well, you have to assess whether or not their past medical history to see if there's any other contraindications like true allergy or Parkinson's disease. I've given you a couple of the dosing here. There is a difference between, essentially an age-related difference between people over the age of 65 and people younger than 65. And then finally, I have at the last, this is something that you can take a picture of. It's essentially a pretty broad differential that Ramya made last year of altered mental status. And so that concludes my portion.
Okay, so I'm going to be going over hypotension because chances are if you're going to be an intern next year, you will get some sort of page overnight that's like, doc, the blood pressure just dropped, the map is in the 40s or 50s, like what do I do with this? So just briefly going over hypotension, I want to emphasize first that hypotension does not equal shock. I'm not going too far into shock, but I think it's important to understand the basic physiology of shock and the different causes of shock that can contribute to this hypotension. So our most common etiologies of hypotension, we usually break it down into 4 buckets. In our first bucket on the left, we have the distributive bucket, and that's basically a very vasodilated state. You've got this infection or an inflammatory process going on, or adrenal insufficiency, one of these processes that just causes mass vasodilation, cytokine release, storm, all of that stuff, and then you just get mass vasodilation and your blood pressure drops because you just don't have the systemic vascular resistance to keep your cardiac output up. So that's distributive shock / one of the causes of hypotension. Next, we have hypovolemic. So if you don't have enough blood to pump around the system, no matter how hard or how well the heart is beating, it's not going to be able to pump very much, and you're not going to be able to deliver that oxygen effectively around the circulatory system. So when you just don't have enough blood and you're hypovolemic, low fluid because you're diarrheaing significantly, vomiting a ton, third spacing a lot, maybe you're over-diuresed, bleeding out somewhere, hemorrhagic shock, all of these different considerations can lead to hypovolemic shock. Next, we know that the heart is a great pump, right? It pumps everything throughout our circulatory system, and usually it works really well to deliver all of this blood pressure throughout our vessels. However, the tricky thing is when you get something like ventricular failure, especially LV failure, the LV is this big, beefy walled cavity that's the ventricle is trying so hard to pump all this blood everywhere. But let's say you have this massive MI and now this LV isn't functioning as well anymore. Now you just don't have that pump activity that's in action enough to be able to produce that blood pressure effectively. So usually I think about, like, is there a valve problem? Is there a rhythm problem? Or is there a muscle problem? Is there an MI, valve, arrhythmia? And then last but not least, our last category of shock is usually obstructive shock. And that is, I think of cardiogenic and obstructive as far as the up-down arrows of shock, kind of in a similar boat. The tricky thing is that cardiogenic shock are things that are intrinsic to the heart and the pump function that are impaired, whereas obstructive shock is things that are extrinsic to the heart. So let's say you have pulmonary embolism, or some sort of tension pneumothorax, and there's something obstructing such that the heart is trying to do its best, but because of this obstructive process and physiology, it just cannot sustain that blood pressure to push forward. So those are the causes. So you are on the floor, you get an urgent call, nurse says the map is 40. What do we do at this point? Quick run through. First things first, you're going to ask the nurse to repeat the blood pressure. Double check the cuff size, double check the placement, make sure it's an accurate read, double check the heart rate, double check the kind of EKG, are the leads on correctly, is tele being monitored, check a full set of vitals, of course, because we always ask the nurse when we get that call, like, what are the vitals? Are they stable? And then some other things to consider is also like for pulse ox, sometimes like nail polish, darker skin color, things like that, they have been shown to throw off our pulse ox reading. So all of these considerations are things to think about when we're actually assessing, like, is this pulse ox reading, our SpO2 actually true? And then the next thing you have to do is you always, always, always go to bedside, because if their MAP is in the 40s, you should definitely be going to bedside right after asking the nurse all of these questions. So you're going to go to the bedside and assess the patient, and then go through the ABCs: airway, breathing, circulation. If they're obtunded, if they cannot protect their airway, if they're like, if that truly is a real MAP of 40 and it's definitely not normal, ask for help. So we're going to skip to the ask for help section if any of the ABCs are compromised. Then if they're not like truly, truly that sick looking, then maybe you can take a step back and be like, okay, well, maybe they're not that sick. Do they have any actual symptoms that they're actually hypoperfusing with this low blood pressure? Do they have any altered mental status? Do they have lower urine output? Are their extremities well perfusing? Because we're thinking about along the lines of like hypovolemic and hemorrhagic shock, if you have a POCUS, it's a great bedside tool to just use, because then you can do a fast exam. You can POCUS the lung, take a look if there's any hemothorax or anything like that, pneumothorax. So POCUS can be a great tool. Then you're going to review the chart, ask whoever is next to you to basically pull up a computer and read the last one-liner, think about the coagulation status. Are they bleeding out? Think about their medications. Did they get over-diuresed? Are they bleeding out? Identify any of the reversible causes. And here is just a list of all the comprehensive labs that are never wrong to get when you're called to the bedside for RRT, or sorry, rapid response because of hypotension. Kind of going through all the shock things, infectious, heart, etc. And then, of course, if you assess the patient and they're sick and decompensated, you immediately ask for help. You just get help involved. You ask your senior, ask your attending, escalate to MICU or step down. And then to advanced care, then you have to call all these consultants to kind of figure out who is going to be taking charge of whatever the underlying root cause of this hypotension is. And then if you're kind of working this up, you need to think about IV access, fluids. Do we need antibiotics? Do we need to be holding any of their home antihypertensives, any potential offending medications like we were discussing on their med list? And then just keep reevaluating. This is someone who I would basically like roughly stay at bedside and just check the blood pressure and keep cycling it. And then think about any extra labs or advanced imaging based on what you think. So that is hypotension. The next topic I'm going to talk to you all about is decompensated cirrhosis. And thank you to Dr. Isa Iligan Yang, who basically provided these slides for us. Cirrhosis is a condition in which the liver is scarred and permanently damaged. So the scar tissue basically replaces all the healthy liver tissue and then prevents the liver from working normally. It can be caused by a variety of things. It can be caused by infection, most notably Hep B and Hep C. It can be caused by alcohol. You can get NASH or mast D cirrhosis, which is a metabolic form, autoimmune, hepatitis, infiltrative. There can be so many different reasons that cause cirrhosis. And decompensated cirrhosis is really important for you to learn about, because all of my cirrhosis patients who ended up with decompensated cirrhosis tend to be the watchers that I'm really, really worried about in the hospital. They have a 9.7 times mortality compared to the general population, and the average survival without transplant is 2 years. There's a 50% mortality in 6 months if left untreated, so definitely one of the big killers. For decompensated cirrhosis, I like to think of it in terms of the complications. So one, what do you have? H stands for hepatocellular carcinoma. So patients with cirrhosis tend to be at risk for hepatocellular carcinoma, or HCC. And to screen that, we usually get an AFB and we get an ultrasound every 6 months. So I think the guidelines are changing recently. So I don't know the most updated ones, just kind of keep an eye on that. They definitely need screening CTs, MRIs. And then for treatment for HCC, if it is caught, ideally we screen it early enough. We could do surgery, we could do ablation or embolization, chemo is an option, and then transplant, of course, is an option as well. The A and HAV stands for ascites. So because you have cirrhosis and this like rock hard liver, now the blood flow that's trying to direct into the liver gets backed up. You get portal hypertension, you third space all of your fluids. And then to treat that, basically we're third spacing everything. So the more fluids you give, the more they're going to third space. So ideally what we want to do is reduce the amount of fluid our body is taking in by salt restricting, and get rid of some of that fluid by giving them diuretics to pee out that fluid. So we do a balance of spironolactone to Lasix for that. We also do paracentesis, large volume paracentesis, especially for basically ascites management if it's getting uncomfortable, if there's concern for infection, things like that, if it's just so much ascites that it's just leading to issues. And then for ascites, TIPS is also another option, basically to reduce that portal pressure gradient. And then another thing, if you have all of this portal hypertension, it can lead to varices. So again, all of this blood that's supposed to direct to the liver is now getting backtracked, and now it's causing bulging vessels called varices, esophageal varices, rectal varices, especially dangerous. And then now we have this really, really high pressure in the venous beds, and of course that can lead to a lot of really, really bad bleeding. So the treatment for that, if you have someone who comes in with cirrhosis decompensated by varices, immediately resuscitate. They need to have 2 large bore IVs. One of my attendings taught me green, gray is good, because I think those are the 16 and 18 gauge IVs, and that's like a universal color code. So make sure they have 2 green or gray IVs. Resuscitate, give them blood, ban the bleed, call GI immediately. And then after the fact, because of course, if they're like bleeding out right now, you don't want to suppress their blood pressure any further or their heart rate. But after the fact, then you can think about preventing with a non-selective beta blocker like carvedilol or propranolol. Another one that you should think about for decompensation is encephalopathy. So because the liver takes care of ammonia metabolism, you can definitely get altered mental status and hepatic encephalopathy. And the idea for this is basically we need to poop out our ammonia now that our liver isn't able to process it. So our goal is 3 to 5 bowel movements per day. You can give lactulose, you can give Miralax, enemas, just make sure they keep pooping and target those 3 to 5 bowel movements per day. And then if you have increased episodes of hepatic encephalopathy on top of that, then you can also start rifaximin. Okay, another consideration is SBP. Emergent, life-threatening, definitely needs a TAP. So definitely do a diagnostic para at the very least if you think that they could have SBP. And how do we know if they have SBP? Well, yeah, SBP has really high mortality. Bedside paracentesis is safe. How do we know if they have it? If they come in, they have a known history of cirrhosis or suspected cirrhosis, they have a fever, they have abdominal pain, altered mental status. Sometimes they can actually present with no signs or symptoms at all. And 13% of them are completely asymptomatic, but they still actually are found to have SBP. So it's definitely one of those things that we just have to have a paracentesis on board to be able to tell. The paracentesis, the cutoff is PMNs greater than 250 cells. So if the PMN count is greater than 250, that's SBP, that's diagnostic. And then treatment options, we usually treat with ceftriaxone, carbapenems if critically ill for at least 5 days. And then in special cases, there's like kind of special procedures and considerations for that. And then after the fact, after this hospitalization, they will need prophylaxis with either Bactrim or Cipro, especially if they've had prior GI bleed, prior SBP, anything like that, ascites, worsening renal function. Last topic I'm going to discuss is asking for code status. It's something that you will have to do with every patient who walks in the door, and it's something that I think needs to be normalized, but it's tricky to normalize in the instant because a lot of patients, they hear like all of these big life or death decisions and they start freaking out a little bit because they're like, oh my goodness, like, is that going to happen to me? So I think the general tip that I would say is to ask this of every single patient, normalize the discussion, and then also assess like what is the extent of their conversations that they have had before. Are they comfortable talking about this topic, or maybe do they need a little bit more of a lead in and for you to establish some rapport before you jump to that? You need to be specific about the different interventions that you're kind of bringing up to them, because CPR is an intervention. And then you can also share that this is a fluid discussion and this can also be revisited. So to set the scene, to normalize this, usually I say something along the lines of, we hope that your hospital course will be uneventful. And I'd like to ask you about your preferences in the event that you were unable to make decisions for yourself. This is something I ask all my patients when they come into the hospital. So then we go into the specific interventions. You have to ask them to confirm their code status, what they want with regards to CPR and intubation. So for CPR, I usually use the wording, if your heart were to stop, which I don't expect, would you want us to perform chest compressions and electric shocks in an attempt to try to restart the heart? And for intubation, I use the language, if you were not able to breathe on your own, would you want us to place a tube down your throat and connect you to a ventilator to help you breathe? And then if your patient does choose DNR, DNI, then we can explore, like, other things, do we want escalation to a higher level of care, ICU, step down, or did they have like some sort of traumatic experience with that setting in the past, and maybe they never want to go back there again? Do they want a central line through their neck potentially, or through their leg to be able to have access centrally? Are they okay with like a BiPAP or a mask to help them breathe? And then again, it's always okay if the patient is getting overwhelmed or can't quite make a decision yet, it's okay to table it and just come back to it at a different time. And that is the end of my section.
All right. Hi, everyone. So I will start my section by talking about managing pain. And to be honest, pain management overall, regardless of settings, is incredibly complex. And given the rise and the worsening of the opioid epidemic, I think it's really important to think about some of the nuances when it comes to pain. And there are more and more research that's coming out with regards to how to effectively manage pain with kind of newer modalities as well. So I'm going to do my best to cut this down to 5 minutes in a very digestible way. One recurrent theme that I'll continue to touch on for each of my topics is always having some sort of organizational framework in mind when you approach any sort of problem and diagnostic. So for pain, what I like to ask myself is, if I see a patient who's complaining of pain, is this pain acute, or is this something that they've been managing for a very long time? Is this something that I'll have to manage while in the short term while they're in the hospital, or is this something that I have to think about on discharge as well? Secondly, it's important to think about the type of pain that they're having, and I'll get into the types of pain in a little bit, because that can influence how you manage certain types of pain. There are many different ways to deliver analgesics, whether it's through oral medications, through IV, we have patches and topicals. There's just such a wide array of options at your disposal. What's also shown in all literature is that a multimodal pain approach is imperative to effectively manage pain. Rarely nowadays does one agent just work well for most patients, especially those who are very sick. And also, don't be afraid to individualize your pain plan to every patient in front of you and adjust accordingly. What's going to be more noticeable to you the more you see patients is that it's really important to pay special attention to certain unique populations because they have their own unique clinical profiles, characteristics that influence how you deliver your care. For example, how are you going to treat the elderly when it comes to pain, or those who come in already altered? It's also important to think about people who are pregnant or are breastfeeding, because there are certain pain meds that can't be given in those situations. So going into types of pain, because again, as I mentioned, it's really important to think about the type of pain that you're trying to manage before delivering the right pain med. So nociceptive pain is one category of pain that involves both somatic pain and visceral pain, things like your typical MSK pains, gout pain, skin like injuries, things like colic pain or angina. Those are kind of the types of nociceptive pain. There's also neuropathic pain, and one of the well-known ones is peripheral neuropathy, especially in the setting of diabetes, people who got chemoradiation, people who have uncontrolled HIV, for example, as well as kind of more chronic things like spinal cord compression and neuralgia. There's also kind of a mixed pain pattern, and this is really commonly seen in cancer patients where they have kind of a mix of both nociceptive and neuropathic pain, as well as other pain syndromes like fibromyalgia and IBS. So this is one table that I like to refer to sometimes when I think about how I'm going to deliver certain medications, because each form of modality can have different onsets of actions and peak levels. So if you're trying to give something that's the IV, typically they take much shorter to reach peak and work much faster, as well as other agents like immediate release orals and immediate release SLs. When I think about what I have in my arsenal, I like to categorize things in terms of like non-opioids and opioids. Generally, you want to reach for the non-opioid analgesics first. Things like the good old Tylenol, acetaminophen, really commonly used, especially on admission. It's used as like a first-line agent to just see how well that's able to control someone's pain. It's pretty effective and generally pretty harmless, although you do want to pay attention to those who come in with like hepatotoxicity or like liver damage at baseline, people who have a long history of severe alcohol use, It's pretty safe to use in those who breastfeed and those who come in with renal impairments, such as AKI, or if they're on dialysis, there typically are no dosage adjustments for those patients. NSAIDs are also one option that you can reach for, and those include ibuprofen, diclofenac, naproxen, and ketorolac, or commonly known as Toradol. And that can be used in many inflammatory pain types, as well as people who recently just underwent an operation or procedure. Many studies have shown that it's actually non-inferior to use NSAIDs in relation to opioids for some pain syndromes. So the problem with NSAIDs is that, especially in a hospital setting, there's a lot of associated considerations when using these, things like risk of GI bleeds, developing ulcers, people who have AKIs can't really use this. You also can't use a lot of these in people who are breastfeeding, as well as those who are in their third trimester of pregnancy, and also caution use in elderly as well. Gabapentin is one agent that you'll commonly see as well, especially in outpatient settings too, where this is generally used in a lot of neuropathic pain situations. But you want to avoid using gabapentins when they're also using opioids and when you're trying to use opioids, because that can enhance the effects of both medication profiles to create more risk of dizziness, more somnolence, and also has some withdrawal potential. Lidocaine and ketamine I just included here because they are options, and especially ketamine is getting a lot more press these days, and a lot more hospitals and institutions are considering, what's the best way of using ketamine in certain situations. And ketamine especially is used in situations where pain is generally poorly controlled on all other like first-line agents, but this is very institutional dependent. When it comes to opioids, I think we're very aware of kind of the common risks associated with opioids, especially things like judiciously using opioids, using them smartly, and also the risk of respiratory depression and constipation. When you want to start someone on an opioid, it's always good to start at the lowest effective dose. So not necessarily the lowest dose, but kind of based on each individual patient's profile, think about what is the lowest dose that you can use to effectively manage the pain or make it more tolerable. You'll often see people be put on oxycodone, typically like 5 milligrams to start with every 4 to 6 hours. And you should pay attention to signs of like constipation and again, respiratory depression when you're putting them on oxycodone. And also hydromorphone is one that I'll mention here too, that can be commonly used, especially when you're like hovering overnight or running to an acute pain event. This is typically given through the IV or also oral if they can tolerate PO. But generally IV is something that I've seen commonly used because it can act really quickly. But the problem is that it also peaks very early and only lasts about a couple of hours. And so thinking about administering analgesics, this is something that you'll have the nurse administer pretty frequently throughout the day, which can cause its own kind of logistical issues. And I just want to mention methadone here because it's nothing that you'll really touch on because that can have its very own like complex management system, and there are methadone clinics out there that manages very closely for those who have opioid use disorder. And so that concludes, one last slide that I forgot to mention is kind of newer forms of opioids, because more and more data and literature is being focused on the use of buprenorphine, a lot of which is used in populations who have a history of opioid use disorder and a lot of chronic pain that's not being well managed. It's being more increasingly used in both outpatient and inpatient settings. And depending on the institution, there are its own guidelines for this use as well. It is metabolized in the liver, so you want to be careful with that, but you can consider using this in those who have renal impairments. And lastly, with some of the long-acting opioids like MS-Contin and OxyContin, these you will also rarely use upfront because they're generally reserved for people who have really, really severe uncontrolled pain, who have chronic pain, typically like your cancer patients, those who are receiving palliative care, where long-term treatment of their pain is expected. And they'll be followed up with in a more longitudinal way. So that concludes pain. And on the similar vein, talking about approach to abdominal pain, which is a topic that is actually more daunting than I had expected when I first went into my intern year, because abdominal pain can be something that is so vague and general and non-specific that, especially when you're getting like acute calls or admissions, it can be pretty tricky to first kind of identify what exactly is up with their abdominal pain. So pretend it's admission day and you're on overnight call, you get this new admit, your senior calls you up and wants you to read up on it and put in the orders. And then when you're chart reviewing, you also get this other page. So for this new admission, you have this 64-year-old woman, history of endometrial cancer, on chemotherapy, here with 4 days of like flu-like symptoms and worsening abdominal pain. Okay, great. What does that mean, right? You also get a page from the nurse about bed 23, which is this 34-year-old transgender patient, recently got bottom affirming surgery with this new rising fever, worsening abdominal distension, and 10 out of 10 pain. And of course, the classic, please advise. So what do you think about when you have these two scenarios where both present with abdominal pain and there's not much data that's given to you and you have very little time to really read up on both patients? Again, I think that especially for me, what's been really helpful is really establishing a framework as the basis of all my, as the starting point for all of my work. Because especially when it comes to abdominal pain, there are so many things that go on in the abdomen, at least in my mind, from different anatomical structures to different physiological things going on to different biochemistry things going on, unicorns, what have you. So where do you even begin to narrow things down and form a differential? One approach is through an anatomical approach, which is commonly taught. I think we all are familiar with the different quadrants, the left, right, lower, upper, epigastric, as well as some of the what I call extra quadrants, or things that structures that are kind of around the abdomen per se and kind of feed into this abdominal pain picture. There's also an approach that some people use where it's superficial to deep, and this can be used in other organ systems too, where you think about from the outside or the external, from the skin down into the structures, so through kind of the musculature, the vasculature, the nerves, the different organs, as well as everything else like in between and the spaces in between. What's also really important is the history that you've gotten. What are the symptoms? What's the time course? Is it acute? Is it chronic? Is it constant pain versus intermittent pain? And all of that can help lead you to different differentials when it comes to abdominal pain. And what's also important, especially in a acute care setting, is thinking about what is potentially life-threatening versus what is not. Generally speaking, but not for everything, if you are really short on time and you just want to blast them with a scan, CT with contrast will usually help guide a lot of these differentials or help guide you down certain lanes with this scan. So instead of reinventing the wheel, I want to refer you to this amazing resource called the Clinical Problem Solvers. And that's something that even in our didactics, we refer to a lot because it has a lot of great schemas to help kind of guide your differentials and guide your thought trains. This is one diagram that they have when it comes to thinking about abdominal pain. So on the top left corner, we think about a lot of the life-threatening situations, things like bowel obstructions, PERFs, vascular issues like, acute mesenteric ischemia, ectopic pregnancy. And then you can think about all of the abdominal organs based on the different quadrants as one approach. So a lot of times you'll have patients come in with epigastric pain, things that you can think about in that region could be like peptic ulcer disease, gastritis, gastroparesis. A lot of times they'll come in with lower abdominal pain too. So think about appendicitis, diverticulitis, different colitis. And then think about all the other organs that kind of surround this area of the abdomen. So the heart and the lungs, they have really bad pneumonia, if they had an MI or developing an MI, if they have really bad heart failure. And then think about a lot of the genital urinary systems too, with cystitis, with like renal stones, with like ovarian torsion, with endometriosis. So think about things in terms of structure, and that can really help you organize your thoughts. So let's say you get some abdominal imaging, and unfortunately, the read comes back and it says that, oh, like things are pretty unremarkable, like no acute pathology is really found on scan. So then you kind of want to think about, okay, if the structures are not really impacted, are there other systems that I'm missing? So from a metabolic standpoint, patients who have DKA can present with like weird abdominal pain. If they have hypercalcemia, they can have abdominal pain. Are there certain medications or toxins that they're having? A big one is like Tylenol toxicity, if they took too much Tylenol. Opioids causing a lot of worsening abdominal pain, especially when it comes to constipation, for example. Some of the functional pain syndromes like IBS, kind of psychosomatic type of functional pains can also lead to this as well. And other things that don't really fit into these categories, like herpes zoster, episodic pathologies, angioedema, as listed here, can also be considerations. But generally speaking, you'll think about kind of the structures and then some of these metabolic, toxic metabolic processes that feed into this. All right, so that's abdominal pain. So next I'll talk about hypertension, especially in focusing on like an inpatient setting. What's important to know is that there's a lot more data and guidelines out there on managing hypertension in an outpatient setting, and a lot less data comparatively is available when it comes to inpatient management of this. So what I do is, again, really establish kind of a checklist or a stepwise fashion of moving through my process of treating someone or managing hypertension when it's an inpatient setting. First, is this something that's an emergency? Do I need to worry about what happens if I don't treat it immediately? So things that can guide that include how they present, what are the labs, what differentials I'm thinking about symptoms versus no symptoms, if they're becoming more symptomatic, if they're having pain, if they're becoming more somnolent and obtunded because of their hypertension, is that something to worry about? And also think about the patient's history. Do they already have a history of controlled versus uncontrolled hypertension? And does that manifest itself in a much more exacerbated way in an inpatient setting? And I think what's important too is, while we're taking care of patients in an inpatient setting, a lot of their medical care goes on as an outpatient. So when it comes to hypertension, what is the long-term goal? Is this something that's going to last like a day or two and it's going to resolve with this disease course? Or is this something that needs to be followed up on as an outpatient? So one of the classic dichotomies we typically think about, or kind of two definitions we think about when it comes to high blood pressure as an inpatient, is urgency versus emergency. So say you have someone who comes in with hypertension, typically defined as blood pressure of 130/80 or greater than. And if they have a really high blood pressure, which is typically defined as a systolic of over 180 or a diastolic of over 110, and they show signs of worsening target organ damage, so things like developing AKI, rising creatinine, things like that, then we call it hypertensive emergency. We formerly called the other type hypertensive urgency when there's evidence of really high blood pressure of over 180/110 or 120, but they're asymptomatic and there's no signs of organ damage. That was used to be called a hypertensive urgency, but now that term is like slowly changing to become asymptomatic markedly elevated BP. And this diagram is from this newly released statement from the American Heart Association. When it comes to hypertension, it's actually really, really tricky to manage as an inpatient because of this diagram right here, which really lists a lot of the patient-related factors, as well as the system or environmental factors. So of course, thinking about their presenting clinical condition, are they in heart failure? Are they in thyroid storm? If they have at baseline uncontrolled chronic hypertension, what are the medications that are potentially contributing to their hypertension? A lot of times when they're acutely ill and acutely distressed, things like pain, being really anxious, having hospital-based delirium, having poor sleep hygiene can also feed into weird blood pressure patterns. And thinking also about the changes between a controlled home environment and a new hospital environment, a lot of those can actually feed into this too. So when you're discontinuing or holding their home antihypertensives, that can also cause weird blood pressure patterns when they're inpatient. So some of the important questions that I like to think about when it comes to treating hypertension is, again, is this treatment course going to be long or short? Am I going to have to worry about this overnight, or do I perceive that based on their pattern of their pressures is going to be a persistent issue throughout their hospitalization? Is this something that I need to worry about on discharge as well, and communicate with their PCP to manage more? Typically, what we want to shoot for, based on a lot of the literature, shoot for a goal BP of less than 160 systolics and less than 100 diastolics. It's important to think about how fast you're going to lower someone's blood pressure, and you want to be careful to not lower their pressure over 30% or 25% over the first few hours, because if you drop too fast, you can cause things like hypoperfusion, but if you also don't treat this fast enough, they can also cause similar issues and lead to really bad adverse effects. So this is basically kind of one way to visualize all the different approaches that you can use from like a pharmacologic perspective, as separated by organ systems. So the point of this is based on what the underlying mechanism is and what organ system is being targeted, there may be different agents that you should consider over others when using those. So this is straight off of Up to Date, another one of your best friends in residency, because it has so much information. One blood pressure medication that you'll see really, really often is the use of hydralazine. And it's something that we all kind of reach to or think about at first, but there are a lot of considerations when using hydralazine too, because it can suddenly drop the pressure a lot. It can also cause tachycardia, cause symptoms like headache and vomiting, flushing. And although this is something that we like to reach for, in general, we should think about other agents as well, because it can cause these unpredictable hypotensive effects. Another drug that you can think about is nicardipine, especially given through IV. I've seen this used, especially in patients who have really, really uncontrolled hypertension, including those who have really failed a lot of the other therapies, and they need to be like on a nicardipine drip, for example. This can be used in patients who are pregnant, postpartum, but you don't want to use this in people who are in acute heart failure. Labetalol is also something that you can consider too. It's also can be given as an IV form, but it can cause a lot of the similar things as like other agents like nausea, some dizziness, bronchospasm as well. It can be used in most hypertensive emergencies, including MIs, hypertensive encephalopathy, also known as PRES, also used in pregnancy and post-pregnancy people. But again, you don't want to use this in decompensated heart failure. So kind of moving beyond symptomatic hypertensive emergencies, what are the ways we can treat severe asymptomatic hypertension? First, it's okay to actually wait and not treat right away within minutes when someone's coming in with asymptomatic severe hypertension. And you can take some time to make sure that this is quote unquote real, make sure that it's staying the same or changing, check their blood pressure again, go through the schema in your mind and revisit a lot of the reversible causes of hypertension. You know, are they in acute pain? Are they really, really anxious? Are there other certain factors from their medications or from the environment that we can control? You can also try and give the next dose of their antihypertensive early on to see how well they do on that. And also titrate the dose of any existing antihypertensives. Essentially, you want to kind of tease out if they present with severe asymptomatic hypertension, is this something that you could just monitor, or you need to act more quickly on because you're anticipating them developing worsening hypertension and developing symptoms, developing end organ damage. So a lot of this is based on bedside exam and careful review of how they're trending over time with their vitals. Okay, so moving on to kind of something different is something that we all love. It's managing insulin. And while there are kind of systematic and standardized approaches that we can use to determine the dose of insulin for people, in reality, you'll find out that there is a bit of an art to this as well. So why do we care about glycemic control? One of the main reasons is that we want to avoid hypoglycemia, that is a blood glucose of typically less than 70. Per a lot of these professional organizations, including the American Diabetes Association, we want to typically aim for glucose levels between 140 to 180 for most hospitalized patients. You'll see literature out there that recommends generally under 180 for a lot of the more seriously ill patients. At the same time, we want to avoid really, really severe hyperglycemia for kind of obvious reasons if they're diabetic. And we also want to make sure at the same time while they're in the hospital that they're getting enough nutrition. So what is kind of this framework that I like to approach managing diabetes with insulin? First, it's important to know what type of diabetes that they're on. If it's type 1, type 2, or if it's neither, if they don't have a documented history of diabetes, is this hyperglycemia more stress-induced? If they have a history of type 1 diabetes, they absolutely have to have insulin at all times. Even if you have to prescribe it at a lower dose than their home dose in order to prevent ketosis, and you have to have this on them regardless of their diet status. Type 1 diabetes can present with a lot of major fluctuations in glucose levels in patients, especially when they're acutely ill. So it's really important to make sure that they are a type 1 diabetic versus type 2. Then you need to determine their dietary status. Are you going to put them NPO? Are you going to have them eat, or are they going to eat very little while they're hospitalized? Figure out what their regimen is right before they're admitted, as well as if you have the capacity to really look at their diabetes history and make sure you know what their trends are with their glycemic control. Generally, we discontinue or hold a lot of their oral agents, including things like metformin, for example, and use insulin while inpatient, generally because insulin is a much more kind of regulated and standardized way of controlling glycemic levels in the hospital setting. And a lot of institutions may have additional ancillary members to help you out with this too, including pharmacy people, if you have a diabetes management team to help optimize a lot of the insulin regimen. It's a simple consult and don't be afraid to utilize them. So of course, there are many different types of insulin, from rapid acting insulin like Lispro, Aspart, to long acting insulin like Glargine and Detromir. At least at my institution, we use Lispro and Aspart a lot for rapid acting or short acting, and we use Glargine most of the time for long acting. So the type of insulin may be institution dependent. So work with pharmacy to determine what things you have on formulary. For those who are on like enteral feeds, tube feeds, things like that, if they're on a short-acting insulin that you want to prescribe them for, they're generally on a regular insulin just because it has a different kind of peak pattern as shown here, rather than put them on like TID Lispro, for example. So how do you figure out how much insulin you give to someone? There's one way to think about it where, you could roughly take about a quarter to a half of what their home dose is and start there and see what happens, quote unquote. There's a more standardized approach and more mathematical way of doing it too, which is weight-based. Things like if they are type 1 diabetic, you may want to use a 0.4 ratio versus if they're average weight but have a type 2, you would kind of half it based on the dosing method. And then you want to split the daily dose of insulin into 50% basal dose and 50% bolus regimen, or how I think about it as like your TID mealtime insulin. you can divide the bolus regimen or the mealtime insulin by the number of meals, and that's typically, breakfast, lunch, and dinner. So divide that by 3. And a lot of times we add a correction scale too, in addition to that, to adjust for if they have certain glucose levels based on that correction scale, they get an additional dose of insulin to manage those levels at that time. So as an example, say you have a patient who weighs 60 kilos presenting with type 2. If we want to go with the weight-based method, we first want to, again, calculate the total dose that we want to aim for. In this case, with the patient with pretty average weight with type 2, we can use 0.5 units times 60, which gives you a total daily dose of about 30. And then your basal dose would be half of that. So half of 30 would be 15. And then figuring out the mealtime insulin dose, we would divide the other 30 from the 60, the 30 by half, and then divide that by 3 per meal. So you would get a 15 basal dose and 5 units of short-term insulin per meal. And then again, depending on each patient's glycemic index, you can consider adding a correctional scale, typically starting at like a +1 or +2 scale, especially if they're NPO. And so I think I'm going to end by saying, again, a lot of this is a good starting point, and it's really important to not neglect someone's insulin orders, especially if they're hospitalized for a long time, because it could be something that's easily thrown by the wayside and forgotten about. And it's always important to work with pharmacy to figure out the right titration throughout the hospital course. And that's my section.
Thank you, Tiffany, Lucia, and Ming for the great information so far. We're going to take a quick break for people to go to the bathroom or whatever they need to do.
All right, everyone, I think we will get started again. So we're gonna start back our second half, talking about something that you guys are gonna do every single day of residency, multiple times a day, at least 2 times a day, generally. And you've probably already done some of this in medical school, and so we're gonna keep it going. So one helpful way to think about sign out is using this framework of IPAS, which really just goes through what are the essential components of sign out. The reason we often perseverate on what sign out is and how to do it is because this is actually one of the most risky times for patient care, where things can get dropped, things can be not communicated through the wealth of experience that the day team or the night team may have with a particular patient, and it can really put our patients at risk. And so by coming up with a really standardized way of doing this, we can try to minimize those things. So just to go through this framework, IPAS, I stands for illness severity. So thinking through just a quick headline, this patient is really sick. This patient is a watcher. And so I've put sort of examples on the side. This is a model of thinking through, if you're a day team resident signing out to the night team, how might you think about telling people about this? So this is our sickest patient. He's a watcher. He's also full code. Then getting into a brief patient summary, something that lets us understand what are the really important things that have led to this hospitalization, what are the conditions that are most salient to that, and what are the elements of the hospital course that are essential to highlight. So Mr. W is a 47-year-old male with alcohol-associated cirrhosis and hypertension. Note that I haven't put every disease he's ever had, but only the things that we're acutely managing. Who's presenting with a GI bleed and encephalopathy. He presented to the ED with hematemesis, found to have a hemoglobin of 6. Today, he got a 1 unit of packed red blood cells and is planned for a scope tomorrow. And vitals have been stable. These are all essential things to communicate because it helps you understand that while the vitals are stable now, you are still watching this patient closely. They're a GI bleeder and you're pretty concerned about him. You have a plan. You've made contact with GI already. There's a plan for a scope. Then comes the action list. So this is the to-do items. This is who's going to do the to-do items, and who can the person actually reach out to if something becomes unstable. So follow up an 8 p.m. CBC. You can transfuse again if hemoglobin is less than 7. The patient has an active type and screen, consent, and large bore IVs. So these are all things that ideally you will have ordered and the 8 p.m. CBC for your night team to follow up on. You're giving guidance on what to do with the piece of information that you're going to get back at probably 8:30 p.m. And you're also telling them what has already been done. You've already obtained access, you've already gotten consent, and you've already gotten the type and screen going. Then you're going to think about what is situational awareness that people need to be knowing about. What you should be planning for what could happen. And so often this is where if someone is septic, you're gonna, or is giving you vibes that they might be infected with something, that's when you might say, if develops a fever, please broadly culture. In the case of this patient, you might say, if he has further hematemesis, call the GI fellow, so that they can more urgently do an intervention that they need to do. And it also tells you if something really is going wrong and you need to contact someone in the family, who to contact and why that person. And then lastly, just thinking about giving space for, especially for the really sick people, giving space for your listener to ask questions about anything that they might not have understood, or to reiterate, okay, so you just want me to follow up on an 8 p.m. CBC. I don't have to contact GI right now, but if something goes down, I can do that. And then at the top, I just put, really, it's hard to do this in our resident workrooms. They're often really busy, they're often really loud, but effective sign out also depends on people actually hearing each other. And so if you find yourself in a situation where you can't hear, you're really distracted, just take yourself out of it and offer that, can we just go outside to sign out? It's really critical for reducing adverse events for patients. Okay, then if I can advance. Okay, then our next topic, very briefly, is just going to be talking about something that some of you may experience. This 2 a.m. page. Mr. J put on his clothes and ripped out his IV, and he says he's fed up and he wants to leave. You might, getting this page, be immediately stressed out and feel your heart rate go up, and you're like, oh no, maybe I need a beta blocker. But what I really want you to think about is just first taking a deep breath and approaching the situation as that's all the information you've received. You don't really know anything else. And take a deep breath, approach this with calm. When you first approach the patient, I think it's really important to not assume that you understand why the patient wants to leave, or, you know, if you might have heard maybe some prior information that might lead you to suspect why they want to leave. But I think it's important to approach the patient as just whoever's in front of you and establish rapport however you are able to. It's important to not assume why, but rather to ask, again, calmly, why they want to leave. Often patients have things going on at home. They might have someone to take care of at home. They might have a cat or a dog, in my case, to take care of at home. They might have a sick family member that they're really worried about. And so assuming, I think, positive intent at all times is generally helpful for building rapport with patients and helping us not damage that therapeutic relationship. Then it's important to then explain calmly why you think they should stay, including the risks you anticipate to them leaving, as well as the benefits that you anticipate to them staying for treatment. And then it is essential that they be able to articulate that rationale. I'm not going to get into capacity evaluation at this time, but these are critical elements of a capacity evaluation. Are you able to articulate the risks and the benefits associated with doing or not doing the action that you are desiring to do? And if all of that happens and the patient decides they really need to leave, I think it's very critical to employ as much of a harm reduction approach as possible so that they are safely discharged. This is not something that we should be seeking to do punitively. It's something that we need to still make sure that they have access to their medications, they have access to all of the medical information they need, that they're getting return precautions as needed. And then the last point I just wanted to make is that there's nothing binding, there's no legal requirement to discharge a patient AMA. And in fact, it has been shown that AMA discharges are usually not beneficial for patient care. It is also not typically beneficial for the hospital. And so this is something that it lives in their chart. It can be something that is associated with stigma. Certainly, if you feel that it's outside of the standards of care and you really believe the patient should remain hospitalized, then of course it is your right to pursue that and to have them sign that paperwork. But I just also want to say that, you know, if you've come up with a plan with them and you think that there's no reason that they need to sign this paperwork that lives in their chart forever, then there's no requirement for you to do that. The last slide I have on that is just a flow chart that if you want to take a screenshot of, it's just kind of a flow chart going through all of the things that we talked about. Okay, and then my next topic is going through GI bleed. Thank you again, Dr. Isa Ilaganying, for many of the slides that we've actually presented, including these. Okay, so going through GI bleed, as you probably remember, one of the main ways that we try to differentiate between the causes of GI bleed is really with the ligament of Treitz. This is very helpful to think about in terms of diagnostics because one, presentation may be different, but also how you approach therapeutics. And then again, and further diagnostics is also important. Thinking about an upper GI bleed, we're often thinking about symptoms like hematemesis. I think it's also worth noting that hematemesis and hemoptysis are not the same thing, and sometimes patients may confuse the two. But worth noting, is the blood coming from the esophagus or somewhere else in there, or is it coming from the airway? And being able to appropriately differentiate that. Or is it melena, which is, I'll have pictures to show you shortly, which is that dark tarry stool substance that it becomes dark and tarry because it's passed through the GI tract and partially digested. And also worth noting that if an upper GI bleed is brisk, if it's arterial or if it's a large varix that's bleeding, it can also be bright red blood per rectum. So that's not necessarily specific to a lower GI bleed, but you may be more inclined to think that if you see bright red blood. Thinking about some of the differential for why you might have an upper GI bleed, anything that can cause GI tract damage, whether that's a pre-existing ulcer or erosive esophagitis or GERD, or a significant amount of NSAIDs that a person has consumed recently because they've been in pain and now they're all of a sudden vomiting blood. These could certainly be etiologies of GI tract damage. And then in patients that you may or may not know have varices, patients with cirrhosis that Tiffany talked about, patients who may have arteriovenous malformations, and then certainly gastric cancers and blood disorders like hemophilia can also present with upper GI bleed as well as lower GI bleed. Then with hematochezia, we're really thinking more about that bright red blood that's surrounding stool. So the stool is formed, and then somewhere along the lower GI tract, it's being coated with the blood that is actively extravasating into the lumen. Things that we're going to think about more here, we're also going to think about, as I mentioned, blood disorders like hemophilia, but we're also going to think about things like diverticulosis or colorectal cancer, intestinal ischemias, and then lastly, hemorrhoids and other like anorectal etiologies. Some general patterns to think about on testing. This BUN creatinine ratio of greater than 36 can be sometimes helpful in pointing you towards an upper GI bleed. If you think about it, the blood is highly nitrogenated and it's being partially digested and then reabsorbed, and so your BUN is going to be elevated. And so this is really why you would see that kind of a pronounced ratio. And then other things, as you know, blood is a cathartic agent. It makes all of your insides very irritated when it's in places it's not supposed to be, and so you might hear hyperactive bowel sounds. And then, of course, if you actively aspirate blood from an NG tube, you will be more suspicious that the person is bleeding from an upper GI source. Okay, now I'm sorry, I should have warned you. Here are the pictures I promised. On the left is melena. So that's really that tarry dark upper GI bleed looking thing, you can see from the periphery of this image that it's still that maroonish color, and so that's a good indicator. Well, this is still blood, but it's very coagulated, it's partially digested. And then hematochezia on the right in the toilet bowl, this is really like bright red and kind of diluted by the water in the toilet bowl. Okay, and then next, thinking about stabilizing the bleed. I'm very sorry to bring back our resistance equations, but I just couldn't resist, no pun intended. Really thinking about what kind of resuscitation are we going to use. You've probably heard you need 2 large bore IVs. What we mean by that is a 16 to 18 gauge needle, much, much better than something that's a standard IV, like a 20 or 22 gauge. The reason for this, as you may remember, is because resistance is inversely proportional to radius. And so the smaller the radius is, the higher the resistance is going to be. And so also confusingly, the gauge size of IVs, the higher the number, the lower the diameter, the smaller the diameter. And so 16 to 18 gauge is larger than 20 to 22. And as you can see from this tiny diagram on the right, a 16 gauge needle, you're going to be able to basically transfuse an entire unit of blood in essentially 10 minutes. So that's very helpful when someone is needing an acute amount of a large amount of blood. And then it should go without saying that you should really look at what meds the person's on, discontinue any anticoagulation if they haven't already been discontinued. Thinking about resuscitation, you may give IV fluids, particularly while you're waiting for blood to arrive, if the bleed has been significant enough. If someone has lost a significant amount of blood, like liters and liters of blood, you really might think about a massive transfusion protocol. That's defined as greater than 10 units of blood in 24 hours or greater than 4 units within the first hour of resuscitation. And so you'll be able to tell based on the history and honestly, sometimes the patient in front of you, if they're really extravasating, you might be able to tell what you need for that. Different institutions have different guidelines on exactly what the transfusion threshold is. Most commonly, we will do hemoglobin over 7 for all comers. If a person has active cardiac ischemia and also unfortunately has a GI bleed, then you'll probably use a higher threshold like 8. And then you might also think about for your resuscitative efforts, if they're not responding to blood products, if they're not responding to IV fluids, then you might think about initiating pressors. Antibiotics I bring up again for our patients with cirrhosis. That will be, you'll start an antibiotic like ceftriaxone to prevent SVP or to prophylax. Octreotide, particularly if you're concerned about a variceal bleed, to assist with splanchnic vasoconstriction, and then PPIs to reduce acidity of the gastric environment and to promote clot stabilization. The latter two sections are really not things that you will be responsible for deciding as the resident on the team, but you will be contacting your GI colleagues, and then based on the nature of the bleed and based on what they're seeing, they may recommend doing an EGD, a flex sig, or colonoscopy. A flex sig is most often recommended for like anorectal disease. Colonoscopy is often limited by the need for bowel prep. And so often, especially if you're with an upper GI bleed, you're going to evaluate with an EGD if a patient is stable enough, or if it's indicated to be performed inpatient. And then I'm not going to get into some of these more advanced IR guided therapies. Okay, and then to talk about acute decompensated heart failure, and thank you to Sanju for her slides on heart failure as well as A-fib with RVR, which I'll be talking about next. So first, I want to start out with some definitions. Of course, you all know that heart failure refers to the inability of the heart to pump out sufficient blood to meet the physiologic demands of the body. But what acute decompensated heart failure refers to is really a clinical syndrome of symptoms that are secondary to hypoperfusion and or congestion because of this reduced cardiac function. And so it's not the case that everybody who has heart failure has decompensated heart failure, just as not everyone with cirrhosis has decompensated cirrhosis. But really, it's the constellation of the clinical picture, the physical exam, the symptoms, and the vitals that we're seeing that lead us to think that someone might be in decompensated heart failure. Very briefly, I just wanted to talk about the fact that most often when we think about decompensated heart failure, we usually are not thinking about high cardiac output heart failure, although it's very important to think about that, and we'll talk about that in a second. Most often, I would say we're thinking about low cardiac output heart failure, and especially within that, we're often talking about left-sided heart failure. This is usually the clinical phenotype that I think most people think of when they're thinking about someone presenting with heart failure. As you know, systolic versus diastolic failure is defined by the cutoffs of ejection fraction that we currently use, where in systolic heart failure, our cutoff is an EF of less than 40%. Diastolic heart failure, we're using greater than 50% EF. And then importantly, right-sided heart failure, which I think, especially in medical school, I think we rarely are taught to think about that as a primary presentation of heart failure, but is especially important to think about. One, left ventricular failure is one of the most common causes of right ventricular failure when the right side of the heart simply cannot handle the elevated pressures that the left side is transmitting. But then other causes like pulmonary stenosis, advanced COPD, advanced interstitial lung disease, and then pulmonary embolism as well can lead to right-sided failure. Left-sided failure, we'll talk a little bit more about all of these etiologies a little bit later, but especially we're thinking about ischemic heart disease, which really should always be at the top of the differential in the United States, where 2/3 of all of our new presentations of heart failure are secondary to ischemia. And then valvular disease, hypertension, dilated cardiomyopathy, though truly with diastolic failure as well, hypertension, valvular disease, all of these things can also be they can also have overlap. And then high output heart failure, I would say that we don't see as much of some of these etiologies in internal medicine, particularly I'm thinking about pregnancy. We rarely treat pregnant patients, unfortunately, in the hospital side of internal medicine, at least at our institution. But also thinking about what are causes of very increased sympathetic tone, like hyperthyroidism, pheochromocytoma, which is also not on this list, anemia, reasons why the heart might be needing to overcompensate for the under oxygen saturation of the blood, and then AV malformation, where the systemic circulation is seeing higher volumes of blood that are bypassing the capillary bed and then being returned to the heart in ways that it's not used to handling. I just bring up this basic distinction to help think about some of the symptoms that our patients might have. They're really symptoms of decreased perfusion versus symptoms of congestion. And you can sometimes think about that as forward failure versus backward failure. Symptoms like fatigue and weakness might result of decreased forward perfusion of like distal muscles, altered mental status from decreased perfusion of the brain, anorexia from decreased perfusion of the gut, leading to low appetite and low ability to actually metabolize. And then with backwards failure or congestion, this is really where we see all of these symptoms like subcutaneous edema, sacral edema, also the pulmonary symptoms like pleural effusions or pulmonary edema that lead to shortness of breath. And then also right upper quadrant, discomfort, bloating, as well as early satiety. And then thinking a little bit more about the clinical presentation and the physical exam. The physical exam, in terms of thinking about this distinction between decreased perfusion and congestion, you might see a narrowed pulse pressure where you see that the cardiac output is actually not sufficient to maintain a map that is adequate, which we'll get to a little bit more in shock. And then you may also see skin temperature changes if you're seeing that the distal extremities in the skin are not being perfused. And then you might also see organ dysfunction like NAKI, liver damage from decreased perfusion of that organ. Congestion, of course, also represents an issue with perfusion if that congestion is bad enough, particularly with cardiorenal disease, where you can see organ dysfunction, not necessarily because there's inadequate blood flow, but because there's a decreased perfusion gradient because there's too much venous congestion. And so you can also see congestion, as I mentioned, through crackles, through decreased lung sounds at the bases, representing possibly a pleural effusion, and then increased JVP and hepatojugular reflex, indicative of just elevated central venous pressures. This distinction of warm and dry versus cold and wet, I think always used to confuse me in medical school, but really what it refers to is how worried are you about the patient's circulatory status and the patient's respiratory status? So hopefully all of you are warm and dry Forrester class 1 right now, and hopefully not in any degree of heart failure. But for our patients that we see in the hospital, we're often seeing them in some of these other 3 quadrants, where if they're warm and wet, they might be perfusing all of their distal extremities. They may not actually have evidence of an AKI, but they might be presenting with a new oxygen requirement. They might now be on 4 liters nasal cannula oxygen, and they've never been on oxygen before, and they actually need some diuresis because they have extensive pulmonary edema from all of this congestion. Patients that we see who might fall into this cold and dry category, these would be patients that we're worried are actually not perfusing their organs, like their kidneys, or who don't have adequate urine output. They might have cool extremities. They may not have pulmonary edema, but that's not an indicator that they aren't necessarily suffering from a cardiac perspective. And we would be worried about cardiogenic shock in that case, that their cardiac output is not sufficient to perfuse the rest of their body. And then patients in this cold and wet category, we're really worried about circulation and respiratory status, where they may be now requiring BiPAP, and they might now be also not really perfusing their kidneys very well. They might also require pressors. And so these are really the patients that we're generally escalating to a higher level of care. This is just a brief schema to go through for reasons why people might decompensate. Very commonly, I'll just mention, very common, I went on vacation, I forgot my Lasix, and now I'm here. I was at a Thanksgiving dinner, I had a huge salt load, and now, unfortunately, I'm here. And then, of course, always thinking about what is the heart doing in order to compensate for something that's happening elsewhere in the body, like an infection, and then that being a precipitant of heart failure. Ischemia as something that certainly can precipitate heart failure through a direct insult to the heart. And then renal failure as something that causes inappropriate fluid handling, not able to excrete that fluid, and now the heart is struggling to manage it the way that it normally would. And then embolism, as we talked about. You all know that you're going to get some basic rainbow labs. You're going to be wanting to look at their electrolytes. You're going to want to look at their blood counts. You're going to look at their end organ function, like creatinine and LFTs, to make sure that there's no ongoing damage, and if so, how to appropriately manage. NT-proBNP can be a useful marker, particularly if someone has never had a heart failure presentation and you're concerned about a new heart failure. That can be very useful. Or if someone has presented for heart failure and you're seeing that they are now presenting with double the NT-proBNP that they've ever had, you might be especially tipped in that direction. Lactate is also important for assessing how much are they falling into that hypoperfusion category. And then certainly if you have concern that the patient is presenting with angina in the setting of their heart failure symptoms, you might consider getting troponins as well. All of this imaging is aimed at identifying how much of the respiratory status is attributable to pulmonary edema or pleural effusion based on their volume status. You're also going to look at the EKG for any signs of acute ischemic changes, really always looking at the prior EKG as well as the new EKG, looking for any new arrhythmias, new heart blocks that could also be contributing to the presentation. And then if you have access to a POCUS or if you have access to echo on an urgent basis, which ideally you will, then you'll be also looking for changes in EF compared to their prior baseline, changes in their chamber size, and any valvular changes. Very briefly, going into just some acute management of heart failure. We're always going to be wanting to diurese them. If they're on a home regimen, the safe rule that we have is typically to double that and make it IV. If they're diuretic naive, you can start with IV Lasix 40 and then up titrate as necessary. There's always concern about kidney function, and often there's confusion about should you diurese if they have an AKI, but it's often difficult to ascertain whether the AKI is in the setting of the acute decompensated heart failure because of forward or backward flow problems. So often we will just empirically diurese, especially to improve their pulmonary status. This is just a very basic table of loop diuretic conversions, and Spenser is going to be talking a little bit more about diuresis. Meds that you might avoid in the acute phase of heart failure, ACE inhibitors and ARBs and beta blockers, especially while you're trying to determine what their renal function is like, as well as whether or not you need to be concerned for cardiogenic shock. Typically, we're also going to avoid in patients with heart failure with reduced ejection fraction, we're going to avoid calcium channel blockers, NSAIDs because of the potential damage that they may exert on the kidneys and our current dependence on the kidneys for volume management, as well as thiazides because even though they are diuretics, they rarely have a powerful diuretic effect and more often are going to contribute to some electrolyte abnormalities, so you might as well skip. And then steroids, if your patient needs them for some other reason, then of course you might consider giving them, but otherwise, empirically trying sometimes in the ED, we will see that we'll just give someone empirically steroids. If there's no reason to do it, it's probably best to be avoided just because of the salt and volume load that it can create. And then all of this, I think, is above all of our, well, except for Ray's pay grade right now, but thinking about the need for vasodilation, inotropes, mechanical circulatory support, and afterload reduction, really those would be things that you would be doing usually in an ICU or a cardiac care unit. And you'll be involving your cardiology team based really on your suspicion for shock. I'm not going to go through this very sadly because it's my favorite schema, but I would recommend that you take a picture of this or something because it's a very, very useful schema to just go through for thinking about the causes of cardiomyopathy. Okay, and then last I'm going to talk about AFib with RVR. So you're going to be called to the ED several times for this, but you're admitting a patient. She's a 62-year-old female. She has a history of diabetes, hypertension, and OSA, and she's not using her CPAP. She's been having palpitations for about an hour, and otherwise she's doing okay. She's not having lightheadedness, chest pain, or any shortness of breath. This is your first EKG, and what you see is that it looks crazy. It's going a little too fast. You count it out and you see that the rate is around 180. The RR interval, if you look carefully, it's really pretty variable and you really can't see any clear P waves, but you're reassured that her blood pressure is 108/68. So as we saw, we looked at this EKG. The definition is really going to be irregularly irregular, no distinguishable P waves. How do we know if it's RVR? You're often going to get paged for a patient is an AFib and their rate is 110. Typically, we don't think of that as rapid ventricular response. We think of rapid ventricular response as being something generally greater than 130. And that's important for thinking about whether this needs acute treatment or not, and how rapidly it needs to be treated. We'll go in the next slide to think about what is urgent, what is emergent, and really when the patient is unstable as being a way to differentiate those things. Really thinking about what are the etiologies of the AFib with RVR. I think between 50 to 60% of AFib with RVR that's seen in the emergency department in the United States is attributable to a secondary cause. It's rarely not its own thing that isn't a consequence of something else in 50 to 60% of cases. And so really looking at what are the electrolytes doing? What is the TSH doing? Is it completely suppressed and this patient is in thyroid storm? Is the patient infected? And actually this is just an inappropriate septic response. These are all going to be essential parts of your workup. Looking at the chest x-ray to see whether there's any new abnormalities in the thorax. Is there now cardiomegaly that might clue you into a potential concern for a heart failure or maybe even a pericardial effusion or any kind of pericarditis? And then looking at cardiac biomarkers can be helpful to try to differentiate some of the underlying causes like proBNP, as we talked about with heart failure. But I will caution that sometimes these markers can also just be elevated because a patient's been in AFib with RVR for a while. And so I would caution to interpret with caution. And then if your differential is going to include PE also, certainly right heart strain can lead to atrial malfunctioning that can then precipitate AFib and possibly AFib with RVR. And so in the appropriate clinical context, if you think ruling out a PE is beneficial, then you can consider a D-dimer, or if your pretest probability is higher, you might consider getting a CTA-PE. And then always with AFib with RVR that has not been evaluated, or with a new AFib, getting a TTE or POCUS to be able to actually look at the structure of the heart. And then going through this crazy diagram, really the determination of how we treat AFib with RVR depends on whether or not the patient is stable or unstable. As I mentioned, you're really going to do whatever you can to figure out if there's any underlying cause, but you really want to figure out if the patient is unstable or stable. If the patient is unstable, so like their systolic blood pressure is less than 90, their mental status is not normal, or they have other signs of organ dysfunction, you're going to really escalate care and you're going to call cardiology, and you're likely going to do a cardioversion. If the patient is stable, then you're going to ask yourself whether they've been anticoagulated for greater than or equal to 3 weeks. If they've already had AFib, they've been taking their anticoagulant, then that's great, and you can proceed with rhythm control, and we'll talk about that in a second. If not, then you're going to ask yourself whether they have a history of valvular disease or whether they have a history of stroke or TIA, for which you would then be very concerned about a hypercoagulability. At that point, if you say yes to that, then you're going to say, you know what, I'm worried that this person's going to throw a clot. I don't want to acutely change their rhythm and flip them into a different rhythm. The reason we're so worried about rhythm control versus rate control is because rhythm control is when you're flipping them from this AFib with RVR, where their atria are not really doing that much that well, and then you're putting them in a regular rhythm where their heart is contracting normally, and now you have the potential to embolize clots that have formed because of this fibrillatory activity. So that's why we care so much about this question of whether or not they have been anticoagulated and whether or not we can do rhythm control. The most important thing for rhythm control then is the ability to anticoagulate and to know that you're doing that safely. So if you've had less than 12 hours of AFib, regardless of the valvular status, et cetera, or rather, if you've had less than 12 hours of AFib, you're going to say, yes, let's go with rhythm control. If you've had between 12 and 48 hours, excuse me, of AFib, then our risk becomes a little bit elevated, and we worry, especially if they have certain risk factors like an age greater than 65, diabetes, hypertension, CHF, which all fit into our CHADS-VAS score, which I'll show you a little bit later. And then we're going to be proceeding with our plan. If they don't meet any of those criteria, we're going to keep going with rhythm control. If they do meet those criteria and we're worried about their hypercoagulability, we're going to try to get a try to get a TEE to evaluate the presence of a clot. And if all else fails, if we're not able to do rhythm control, we can do rate control. The only cautions I'll give you about rate control are calcium channel blockers or beta blockers can be great in patients. Calcium channel blockers are great in patients who do not have a reduced ejection fraction, in which you're worried about that contractility. Beta blockers, you want to be careful about if you're worried about shock. And digoxin can be a good option for patients with reduced ejection fraction. And then for rhythm control options, what we commonly use is amio, which you'll load and then start them on a drip. And then I'm not going to go into this whole classification system. And then anticoagulation, you're going to really do on the basis of the CHADS-VAS score, which you all know. For our patient, I believe her CHADS-VAS score was 3. She did not meet any of these has blood criteria. And so we are going to anticoagulate her. And we're probably going to start her on a heparin drip and then transition her to an oral agent, with which she will be discharged outpatient.
Thanks, Ramya. Next. Okay, so I kind of have like a number of different like chalk talks that like are just in my iPad, so I just uploaded them. So bear with me on my handwriting, but this is just a very quick and easy way to think about when you're diuresing someone, as Ramya was saying, when someone comes in with heart failure. First of all, threshold dosing. So you see there on the graph, urine output is in the y-axis, the dose is in the x-axis. You want to make sure you hit a certain dose before you will start to see an effect of the medicine you're giving. You want to make sure you're not hitting too little. But also, if you give too high of a dose, you're going to have less return for the dose you're giving. Of note, CKD, because the drug works by the medicine getting into the loop of Henle. In CKD, you want to start with a pretty high dose in order to get the medicine there. And in heart failure, you see a less of a maximal effect. In terms of timing of effect, you see the peak effect of diuresis 30 minutes in, and that's when you can actually check a spot urine sodium to see how effective you're diuresing someone. In the hyperacute setting, let's say you have a patient decompensating with hypoxia, and you dose a diuretics, you'll notice that 5 minutes in, they will start to feel better. And that is not because of the diuretic effect, it's because of venodilation via prostaglandin, decreasing LV filling pressure. So that's going to happen right away, but they're not going to start to pee yet. But the diuretic is going to work in that setting. The medicine will last for about 3 to 4 hours, and that's when you're thinking about doing the repeat ISNO to see if you want to redose them. A couple things that are very important for loop diuretics. One, they are nephroneutral. There's nothing inherently bad about them to the kidneys. And because of that, number two, do not be scared to diurese them, even if you see a creatinine bump. You have to think about the creatinine bump. What is the etiology of the creatinine bump? Is it because they are congested because of cardiorenal syndrome? Or is it because they're overall very volume down and they are in just pre-renal, hypovolemic pre-renal injury? So think about your etiology and really dose based on your clinical exam. If they look congested and you see a creatinine bump, keep going, don't stop. Transient rise in creatinine does not have poor outcome. So do not be scared if your volume exam is that they are very congested. Decongestion is key. Again, based on your clinical exam. A couple pearls for dosing diuretics. Dose early. So time is money for your patients. The quicker you can get them out, the better. So you want to start, the first thing you go in, if you know you're going to start diuresing this patient already, just dose them. Give them the dose and don't wait until rounds, because then we all have those days where we wait until rounds and then things get behind and then nursing hasn't dosed them yet, and then all of that day is wasted to diurese them. Dose trial, Ramya had already talked about this. So start with 2 to 2.5 times the PO dose and convert that to IV. So they're on a PO 40, give them IV 80 to 100. You can spot check a urine sodium about 30 to an hour after you give the dose. It should be greater than 50 to 70. If not, you just double the dose right there. Don't wait for that 4-hour ISNO check. Frequent reassessment, keep checking your ISNOs to see if you need to redose them. And don't dose them at like 7 p.m. or 8 p.m. That's really mean. You're going to make them get up and pee all night, and they may fall. Lots of complications. And that's why we dose early. Next, prevent post-diuresis sodium retention. So the kidneys is going to kind of upregulate sodium retention after you dose the first Lasix. So you want to dose more than 1 time a day if you're truly trying to diurese them. And you can always augment with metolazone or thiazide diuretics. So you will give them all at the same time. And then lastly, monitor lights and chloride depletion alkalosis. So the biggest thing you worry about when you're decongesting quickly is electrolyte derangement. You can very easily monitor that by just repeating your BMP and MAG and FOS. Sometimes on the cardiology floor, we would diurese up to like 8-9 liters net negative a day. So you really can go pretty aggressive if you really think they are fluidly volume overloaded. so of course you're going to replete potassium. Of course, you're going to replete magnesium. The other light to think about a lot is chloride. So you will a lot of times see these patients go into chloride depletion alkalosis, previously taught as contraction alkalosis. Now studies show that it's nothing about volume contraction. It's about chloride depletion in the kidneys, where bicarb and chloride are needed for, chloride is needed to exchange bicarb out. So in those settings, you can actually just replete the chloride and keep going. So in my institution, there's not really something fancy you can replete the chloride with, but you can use KCl, which is easily available and target K below 5. And there's emerging data in the heart cardiology world about how chloride really plays a role. Previously thought to be due to sodium in like diuretic resistance. Okay, can we go to the next slide, Ramya? Thanks. Okay, quickly, hypoxemia next. So you've been taught there are 5 causes of hypoxemia. We're going to go through all of them plus one more really quickly. And then we are going to go through the alveolar gas equation really quickly at 9 p.m. On a Friday night. So first, low atmospheric oxygen, you see there on the first schema. So you have, of course, low oxygen around, so they're going to be hypoxemic. I think the extreme example would be like space. Number 2, hypoventilation can cause hypoxemia alone. And usually when that happens, you are worried about this patient. And this is when the alveolar gas equation comes in handy. When you have a patient who has some sort of obstruction like COPD or asthma or like neuromuscular disease, when they are hypoxemic without another reason, you're truly worried, because that means they're about to really decompensate, that they're at the end of their compensation. And you can use the alveolar gas equation to quickly look at that. So if you look at the equation simplified up there, the alveolar oxygen pressure is going to decrease as your PaCO2 go up. And that's when you don't see an AA gradient, when the AA gradient is normal. So that's when you're worried, when someone comes in with some sort of obstruction etiology and is hypoxemic. Now, next, let's go to diffusion defect. This is classically seen in ILD. Of course, you have more barrier for the gas exchange to happen. Number 4, when you have a shunt, either that's intrapulmonary or intracardiac, the blood bypasses the alveoli directly. And then number 5, you have VQ mismatch, which is probably going to be most of your hypoxemia in the hospital. Either the problem is because of the ventilation, such as in pneumonia, or a problem is because of the flow of the Q, such as in the PE. And last but not least, the 6th cause of hypoxemia is low central venous sat. And we often see this in the critical care setting when there's a very low cardiac output. So again, half of these are going to be, there will be an elevated AA gradient, meaning that the lesion is at the alveoli, and half of these will be not there. And that's when you use the alveolar gas equation. Ramya, can you go to the next slide, please? Okay, quickly talking about asthma, emphysema, bronchitis, and the broader category of COPD. In adults, very much on the spectrum. Asthma is bronchoconstriction. Emphysema is loss of elasticity causing alveolar collapse. Bronchitis is chronic inflammation causing obstruction. All of them has to do with obstruction. So quickly about their management. For asthma, your nebs and your steroids are going to be your mainstay of treatment. As soon as the steroids go in, the better. It doesn't have to be IV. It can be PO. You often want to taper them because they respond well with steroids. And that's how the pathophysiology of the inflammation works. You can escalate this by going into continuous albuterol, systemic beta agonists like terbutaline, magnesium with a bolus, because oftentimes they will have transient hypotension from magnesium's calcium channel blocking the smooth muscles in the arterial side as it works by blocking smooth muscles in the bronchial side. Epinephrine is your friend. You can give it IM. That's totally fine. And of course, BiPAP for positive ventilation to try to help them go. On discharge, you want to put them on SMART therapy, which is a single inhaler that contains both the inhaled corticosteroids as well as the fast-acting beta agonists. So those are your Dulera and your Symbicort. It has to be Dulera or Symbicort because they have a fast-acting beta agonist that can rescue them as well as use them for maintenance therapy. So one inhaler showed to have good outcomes. For COPD, exacerbations definition is anything like increased dyspnea, cough, or sputum production. When you see a patient coming with COPD, they have any of those, you're concerned about a COPD exacerbation. Your mainstay of treatment is kind of similar, is NEBs, as well as steroid burst. These you don't have to taper. You can give them 5 days and you're done. And always think about whether you want to cover for pneumonia at the same time, whether that is CAP or HAP. And of course, BiPAP as well. If they are chronically hypercapnic, you want to target their oxygen sats at 88 to 92%. And importantly, in dark skin individual, those who have more pigmentation in their skin, there is occult hypoxemia that we see. And this is coming from the COVID literature. And so you want to actually target their pulse ox a little bit higher, usually about 4 to 6% in those individuals, because their pulse oximetry is not as accurate and can read a little bit lower. In terms of why we do that, it's really because of VQ mismatch and VQ matching. So you will hear sometimes that people say, we don't hyperoxygenate because oxygen depresses respiratory drive. That has been debunked. That is not the etiology of how this works. So the schema here shows on the left side is a usual alveoli on the left side with proper vasodilation when there's oxygen, and then hypoxic vasoconstriction when there's poor ventilation. That the lung is smart. It's going to hypoxic vasoconstrict and then promote VQ matching. Where there's ventilation, there will be blood flow. When you hyperoxygenate, all that oxygen is going to diffuse down the concentration gradient and then dilate that blood vessel, causing more VQ mismatch. And because of that, all of that CO2 is going to build up and then cannot get out because of the obstruction. So in that case, that's why you really want to target their oxygen level a little bit lower than usual. You don't want to hyperoxygenate them because you want to promote VQ matching and just follow along with what the lungs are already doing. For COPD patients, discharge them on triple therapy. So that includes a LAMA, a LABA, as well as a steroid, especially for moderate to severe, is shown to have better outcomes. Get them home oxygen if they are satting less than 88%, and then get them to quit smoking, vaccines, and pulmonary rehab. Lastly, kind of core tenets in thinking about obstructive lung etiologies. So number one, it's really about obstruction. It's not about radiologic findings of emphysema. It's not about their baseline oxygen requirement that predicts disease severity. It's really about obstruction. You have to search for their PFTs, and you have to be suspicious when the patient comes in with COPD exacerbation that does not have a PFT. Number two, no wheezing does not reassure you at all, because no wheezing could mean that there is such poor airflow that patients are actually not moving air at all, and that they are about to decompensate and about to code. So you really want to be able to hear air movement, and you should be worried when you don't hear anything. Number three, BiPAP trial first and try to avoid intubation as much as possible, because intubation, you're going to cause transient hypotension, transient worsening of respiratory acidosis, and then bronchospasm. So all of those will worsen what you're already trying to treat. Number four, hypoxemia secondary to hypoventilation equals bad. So when you see a patient with asthma coming in who is hypoxic on 6 liters without any signs of like pneumonia, you are very worried. And that's, again, going back to what we were saying earlier about the alveolar gas equation. When they don't have an AA gradient and they are hypoxic, that means they're about to decompensate. So you should be worried in those cases. Next. Okay, hyperacute hypoxemia. This is when it's really relevant on the floor when you're on nights and the patient is decompensating. This is taken from Clement, who is one of our alumni here at Penn, who does a lot of other social media funny stuff. But this is his schema that I am borrowing. So first, a patient is hypoxic. You want to know if they're stable or unstable. If they're unstable, call anesthesia stat and go ahead and intubate. Next, if they're stable, you just do a quick exam. Listen to their lungs and then listen to their neck. So many times people forget to listen to the neck and then think that the patient is having wheezing in the lower airway when it's just transmitted upper airway sounds from stridor. And that definitely changes your management as well as your differential. So if you hear stridor up here by the neck, it's an upper airway obstruction. You're thinking anaphylaxis, foreign body, angioedema, subglottic stenosis, vocal cord dysfunction, as well as like excessive dynamic airway collapse. When you're hearing lower airway findings, you're thinking it's blood, pus, water, or if you don't hear much, they can have a pneumo, or it's pleural disease, or it's atelectasis. So in those cases, imaging will be your best friend to kind of identify what's going on. If you have a completely normal lung exam, normal imaging, you can give an oxygen challenge. Obviously, at a rapid, all of these things are happening at the same time. If their oxygen improves, you're thinking this might be a PE, especially if they're tachycardic. Again, normal lung exam. If you don't see an improvement on their oxygen, you should look at their gas. Their gas should tell you whether they have a saturation gap. A saturation gap is when the calculated saturation from the PaO2 is different from your post-oximetry. If there is a gap, you're thinking there's a dishemoglobinemia, like methemoglobinemia. If there's no gap, you're thinking there's a shunt. Maybe this patient has pulmonary hypertension and their RV is so high pressure that they popped open their PFO and they're having intracardiac shunt. So all of these kind of quickly kind of narrows down your differential based on your exam and what you're seeing at the moment. Next. All right, next we're going to talk about hyponatremia, our favorite topic in internal medicine. Okay, so this is a framework taken by one of our nephro fellows. Very simple approach with just 4 questions we are asking. It is sequential, so you want to go this by sequence, even though a lot of times we order these labs all together anyway. Number 1, is it real? Is the hyponatremia real? Number 2, what is the renal function? Are the kidneys even working? Number 3, is ADH on? And number 4 is RAS on. So so for each of these questions, there's something you can do, some lab value you can check to kind of identify your problem. So is it real? You're going to get a serum osm. Go ahead and add that osm to the first lab that was drawn in the ED where they are hyponatremic. If it's elevated above 295, this is hyperosmolar hyponatremia, which means something else in the body is drawing in free water and the body is appropriately lowering the sodium. So you're not necessarily worried about the hyponatremia per se, but you're worried about what is that extra osm in the body, and you want to figure that out. So check a glucose, make sure they haven't gotten a contrast recently. Mannitol is another thing. BUN and alcohol. Certainly lots of alcohol can do this, including different types of alcohol. If it's normal, so you have pseudo hyponatremia, serum osm is normal, that you're thinking about they have elevated protein in their blood or elevated lipid in their blood, and this is purely a lab error. This is purely a lab error when they're calculating for hyponatremia. The lab estimates how much serum you have to calculate the sodium level, and when you have a lot of other things in the blood, that serum level is underestimated, and so you have this hyponatremia that you see in the lab. So this is fake. You don't have to worry about it unless you have hyper plus hypo. If it's real, so you get a serum osm is less than 275, you move on to the next question. You think about the renal function. What is the GFR? If the GFR is less than 30, you're done. Treat the underlying cause. They are hyponatremic because their kidney is not working, because their kidney is the primary thing that regulates sodium in the body. So treat the AKI or dialyze them for the ESRD. Next, let's say their kidneys are working, so your renal function is greater than 30. You ask, is ADH on? And for that, you check a urine osm. If the urine osm is less than 100, the ADH is not the problem here. So the problem is either there's not enough solute, for example, they are on a tea and toast diet, or they have primary polydipsia. There's too much water. They're just drinking too much water for the kidney to even catch on. In those cases, in low solute intake, you want to be careful with your fluid correction because the correction can be very, very rapid. Let's say your ADH is on, so your urine osm is greater than 100. Next, you want to ask, is RAS on? And for that, you're checking a urine sodium. If RAS is not on, which means your urine sodium is high, you're thinking this is either an ADH problem or a problem where you cannot turn on the RAS, right? So ADH problem, SIADH, syndrome of inappropriate ADH. That's the problem. Adrenal insufficiency, hypothyroidism, those are kind of like these endocrine hormones are needed to turn on RAS. So that is on your differential as well. We also see this in cerebral salt wasting syndrome as well as thiazide diuretics. Now, let's say if you're RAS on, you're thinking the kidney is doing everything it can to reabsorb whatever it can. So for some reason on the arterial side, the kidney is not seeing enough volume. And that's why the kidney is turning on ADH and turning on RAS to reabsorb everything it can. And what's on your differential is really based on your history and your exam. So hypovolemia, there's just not enough coming through the arterial side. Congestive heart failure, they are volume overloaded, but on the arterial side, they are congested and the kidney is just not seeing enough volume on the arterial side because everything is on the venous side. Cirrhosis, they are vasodilated everywhere. And then they are leaking fluid to third spacing everywhere. The arterial side is just not seeing enough fluid. And nephrosis, where they're losing protein through the kidneys. And again, similarly, third spacing everywhere. So you cannot see, the arterial side cannot see the volume. So hyponatremia, only 4 questions, essentially 4 labs you check, and the rest are based on history and exam. Let's go to the next slide. Okay, acid base. All right, I'm going to show you quickly a couple different approaches to acid base. This, again, is going to be based on the question you're asking and what tools you can use for those questions that you're asking. So first, let's go over the traditional or the Boston approach. So the Boston approach is developed in the US. This is what we are most all familiar with. The idea is you're using the Henderson-Hasselbalch equation to think that the lung controls the PCO2, the kidney controls the bicarb, and together they are both independent variables that then drive what the pH is, right? That's the concept. So the first, of course, you're looking at the pH, and the question you're asking is, are they acidotic or alkalotic? So less than 7.4. We're moving on to the next question. Are they in respiratory or metabolic acidosis or alkalosis? So if the PCO2 is in your direction of acidosis, then you have respiratory acidosis. If the bicarb is going down in direction of your acidosis, then you have metabolic acidosis. Same thing on the respiratory side, respiratory alkalosis when PCO2 is low, metabolic alkalosis when your bicarb is high. A quick note on bicarb coming up in metabolic alkalosis, you can quickly check if they are chloride dependent. Again, not contraction alkalosis, it's chloride depletion alkalosis. You can go ahead and give them their chloride back, either by the KCl I talked about, if volume is not a problem, or give them sodium chloride. Give them their volume back with their chloride, because that is what's going to correct the alkalosis. Okay, so the rest is really focused more on metabolic acidosis. So whenever you see a metabolic acidosis, you're always asking 2 other questions immediately. First, is there a mixed respiratory acid-base disturbance in that going with that metabolic acidosis? And the tool you're going to use for that question is Winter's formula. Easily found, I don't have it memorized, easily found online. And that's your friend in terms of thinking about, is there a mixed respiratory process happening? And then the next question, of course, is the anion gap. The anion gap, you always correct for albumin because albumin contributes to the anion gap. The normal I think about for the anion gap is 12. So if it's greater than 12, you're thinking there's extra acid in the body. When it's less than 12, you're thinking the problem is not extra acid. The problem is you're somehow losing bicarb. So the next thing you can check in non-anion gap metabolic acidosis is then you can ask, where are we losing the bicarb? Is this because of the kidneys or because of GI loss? And that's when you can use a urine anion gap. That's the tool you use to answer that question. If it's positive, it's from the kidneys. If it's negative, it's from GI loss. I won't go into the details of how that works, but essentially the urine, you want to know if the kidney is adequately secreting acid in the urine. And if it's not, then it's coming from the kidneys. For anion gap metabolic acidosis, the next question you want to ask is the delta-delta. So the delta-delta is kind of daunting and complicated with an equation. The way I think about it is very simple. You have anion gap normal at 12, bicarb normal at 24, just double that, right? So 12 and 24. when you move up on your anion gap, you should see the same decrease in your bicarb. So that's your anion gap went from 12 to 16, so it went up by 4. You should see your bicarb go down from 24 to 20 because it should go down by 4, plus minus 2 or 3. And that should account for that. If it doesn't account for that, you're really saying that there's another metabolic disturbance happening, whether that is metabolic acidosis, non-gap acidosis, or a metabolic alkalosis, right? And we can see that in DKA, for example, where you have a high gap acidosis where they're also vomiting a lot, causing metabolic alkalosis at the same time. So a delta-delta helps you figure out whether there's another metabolic process happening. And then the other question you want to ask is, are there other osmotically active things in the blood? And you can use the osmolar gap to calculate that. And that essentially tells you, is this ethylene glycol? Am I worried about methanol that's causing this high anion gap acidosis? That's also osmotically active in the blood. There is an awesome review from the New England Journal on the Boston approach that's listed here. Can we go to the next slide? The next one, I want to introduce you to the Copenhagen approach, which is the base axis approach. You will often see this reported on the gas. It's less popular here in the US, developed by doctors in Copenhagen during the polio pandemic there. What it is it's a quick way for you to assess whether there is a metabolic disturbance if you completely ignore respiratory disturbances. What it does is the gas machine sets the PCO2 to normal, to 40. And then it simply titrates your acid-base disturbance to a 7.4, to neutral. And then will tell you how much base axis there is. If it's greater than 3, there's a metabolic alkalosis happening in your blood. If it's less than -3, there's a metabolic acidosis happening in the blood, right? And that doesn't have to be pathologic. It just tells you if you ignore respiratory changes, what is the metabolic disturbance happening? And that gives you a very quick idea about what's going on in the body. And the idea is that they developed this because they say, hey, the Boston approach is too simple. It's not just bicarb in the kidney that's the buffer. There are other buffers in the blood, right? So this takes into account lots of other buffers and just gives you a quick way to assess acid base when you are at the gas machine. All right, next. I'm going to skip the strong ion difference. We're at 917. This is a really cool, awesome approach to acid base. You should read about in the New England Journal as well here, attached here. This explains why hyperchloremic acidosis is a thing and why certain fluids are better than others, but we're going to skip that.
Thank you, Spenser, for finishing out our wonderful session. That concludes the content portion of our session. I'm going to drop